Okay, good morning or afternoon, everyone, depending on where you are, and welcome. My name is Verena Maas. I'm an advisor at GIZ, working with the sector program on health, and I'm also the One Health community manager at PANORAMA. And today I will be moderating. It's a pleasure to have you all here today. I think we can start now. And before we start with the presentation, I would like to share my screen for some housekeeping rules. Can you see my screen?
Not yet.
No?
Yes, it looks like it's coming.
Okay, perfect. So, yeah, probably everyone knows these rules, but please mute your microphone for the duration of the presentation. If you want, you can have your camera on, but be aware that we are recording. And if you have any questions, please use the chat function. At the end, we will have a Q&A session, and there we can address the discussion at the end. And if you want to raise your hand during the discussion, you have to click on the reaction button, and then you can see there that you can raise your hand. So this is for housekeeping. And now we can start. So the webinar of today is part of the One Health Festival, which is held alongside the One Planet Summit in Lyon, which is a global event bringing together governments, international organizations, and civil society to drive action on our planet's most pressing challenges. At the end, I'm going to post a link to the festival if you're interested also in participating in more events. Our session today is titled From Vision to Action, Implementing One Health in Practice, and it is organized by Panorama One Health together with GIZ and IUCN. So the goal sounds simple, but it's very important. How to bridge the gap between conceptual alignment of One Health and real-world implementation by shining a spotlight on concrete field-tested solutions. Today we're going to have two speakers who are solution providers at Panorama, and they're going to share practical lessons, honest reflections on barriers, and transferable insights for anyone looking to apply One Health principles in their own context. So maybe for those who are newer to the concept of One Health is an integrated approach that recognizes the health of humans, animals, and ecosystems as deeply interconnected and interdependent. Challenges like zoonotic diseases, antimicrobial resistance, food safety, and climate-related health risks cannot be solved by any single sector alone. And One Health calls for collaboration across human health, veterinary, environmental, and other disciplines. So today, our first presenter is going to be Dr. Nicole Fascendini. She is a One Health advisor at Amref Health Africa. Nicole is a medical doctor and public health expert with over 20 years of experience in health system strengthening, reproductive health, and community-based programs across sub-Saharan Africa and Southeast Asia. She works at the intersection of policy and practice, collaborating with NGOs, UN agencies, and governments to institutionalize and operationalize One Health. And she is an active member of the HEAL consortium. Miko will be presenting the solution One Health units as innovative models for health service delivery and pastoralist communities of East Africa. This initiative demonstrates how integrated human, animal, and environmental health services can be co-delivered at the community level in remote pastoralist areas of East Africa. The model is designed to overcome the structural barriers faced by mobile communities who are often underserved by conventional health systems, while also building resilience against zoonotic and climate-related health risks. Nicole, the floor is yours.
Thank you very much, Verena, and thank you all for attending the session. I'm going to share my screen. I hope you can see it. Can you see it?
Yes, we can see it.
Perfect. So it's an honor for me to be here with you today, representing the EEL Consortium to present the One Health Unit as an innovative model for health service delivery in pastoralist communities in East Africa. So before starting with the project itself and presenting what the approach is and how it develops at the community level, I'd like to say a few words on the nomadic pastoralist community we are working with. Nomadic pastoral community in the Horn of Africa are livestock dependent for their food, for their income, for their livelihood in general. They are constantly on the move in search of water and pasture. And because of their mobile lifestyle, but also because they are often neglected by the national system, they have limited, I would say extremely limited access to essential services, including health services and veterinary services. And yet they are highly vulnerable to shock. They are highly vulnerable to and particularly exposed to infectious diseases, zoonotic diseases, but also particularly vulnerable to environmental shock, like drought, flooding, and they live in a degraded landscape that have been heavily affected by climate change. In this setting, the HEAL Consortium started a project back in 2018. The HEAL Consortium is structures composed of three main organizations, which somehow reflect the organization or mirror somehow the three dimensions, the three pillars of One Health. And together, the three organizations really support each other and complement each other, bringing in the consortium expertise from the human health, animal health, and the rangeland health. So the consortium is led by Vétérinaires Sans Frontières, which is responsible for the component on animal health. Then there is AMREF Health Africa, responsible mainly for the technical component on human health. And then the International Livestock Research Institute, which brings in the expertise in rangeland health, of course, but also they are leading the research and the training component together with the associate partner, the University of Liverpool. We have other two associate partners which are dealing on specific activity. SEDA, which is supported implementation of the activities in Somalia, and TRIM, which is a private actor, which is supporting with the community-based observation network. The consortium, of course, work closely with local authorities and local community, which are integral part of the governance of the project. Before going again into the project, I'd like to say a few words on the One Health institutionalization in the region. The project develops in Ethiopia, Somalia, and Kenya. And I think that in the three countries have made significant progress in terms of operationalizing and institutionalizing the One Health approach. The three countries have One Health national One Health strategic plan. And most of all, they have already established national coordination mechanism, which have also cascaded into sub-national coordination mechanism. And I would say that these structures have, of course, particularly helped the implementation of the project at the community level. So, but now focusing on the project, as I was saying, we started back in 2018. We have the fortune, I would say, to have a 12-year project, which is structured in 4 different phases. We started with what we called an inception phase, which mainly focus on context mapping and trying to understand the needs from one side, but also how the One Health approach could really support the communities, the local communities. Between 2020 and 2024, we had this first phase in which we launch and test the model, the One Health Unit, the integrated service delivery model. And we are now in the second phase where we are consolidating the approach and generating evidence, which hopefully will help us entering in the third and last phase, which will mainly focus on policy influence and the institutionalization of the approach. As you can see on the right side, that's the map of our project area, and the shaded area are where we are basically working. But as you can see, these are really areas which are arid and semi-arid. With this visual, I would like really to summarize the structure of the project. The project is based on three key components, or what we call the three collaboration platform. At the center, we have the One Health Unit, which deliver integrated services to local pastoral communities. We have discipline services, sector-specific services, like human health, animal health, and rangeland health services, and what we call cross-cutting services as well, where the different professionals work together to deliver integrated services like environmental health, capacity building, data-driven decision-making, and outbreak response. The innovative component of the project builds on the fact that the One Health Unit is co-managed by local authorities through the One Health Task Force and multi-stakeholder innovation platform, which is the collaboration platform of communities. So communities and local authorities work together to plan, implement, and monitor the One Health Unit. Yield partners and other partners provide a technical and logistical support. When we started, of course, we also provided a lot of financial resource, but gradually, as we will see later, financial contribution is becoming less and less, and the technical component remain there. So going straight into the description of each and of these collaboration platform. Let's start with the One Health Unit, which is the core component of the project. And it is the new service delivery model. It's comprised of 5-10 service providers and community-based actors from the human, animal, environmental, and rangeland health sector, which work together to provide integrated services to local communities. This can happen through either mobile services, through outreach activities, or through static services from fixed facility. The One Health Unit is adopting a flexible approach. So the modality, the model of the One Health Unit really change according to the context and fully align with the local needs across the different locations, I would say, and of course, across the different countries. So in settings, in villages where we do not have health facilities, the One Health Unit model is what we called a community-based model. So the main mode of delivery is mobile. The multidisciplinary team of service provider move along the pathway of the pastoralist community, and they deliver integrated services, normally under the shade of a tree or close to water sources, water point, or any other gathering point. On the other side, in villages where the health facility, the health structure, the health system is functioning and operational, so we do already have facility that do provide both human and animal health services. These health facilities are put into a sort of network and they work together. So they plan together and they share data, they collaborate together, but they still provide independently their services to the community. So we call this model the facility-based services. So the services are still provided from fixed facility, but at the same time, the collaboration among the different service provider help them to provide integrated services. Again, the two facilities can work together in planning for outreach services, so from mobile services, for specific activity like vaccination campaign, or in case of response to outbreaks, or again when to reach those communities that are more vulnerable and more far and hard to reach. We have also a third model, which is the combined facility One Health Unit, which is typical in Somalia at the moment, where health facilities are not always available, but the security issue does not allow to rely completely on mobile services. So what the project did, we established some fixed facility that provide combined services. So from the same building, we have delivery in separate room of human and animal health services. What is the multi-stakeholder innovation platform? This is the collaboration platform for community members, and it's quite important in designing, planning, implementing, and monitoring the One Health Unit. The multi-stakeholder innovation platform comprises of 15, 20 members, community people, that represent local and religious leader, service provider, usually community-based service provider, traditional healers, teachers, educators, and then we have, of course, representatives from the from the women and youth groups. We build them on infrastructure, community infrastructure that are already available, and MSIP members are trained and supported to meet on monthly basis to analyze health-related problems and to collectively identify solutions to these problems. And the One Health Task Force, on the other side, is the collaboration platform for local authorities. So it's comprised normally 12 members from relevant One Health departments. So we have representatives from the health, the livestock, the agriculture, and natural resource management department, and sometimes also other representatives, for example, from the women affairs or from the education department. And all these local authorities work together to support the implementation of any One Health initiative in their territory. Normally, the One Health Task Force resemble or mirror the national structure of multi-sectoral collaboration. For the One Health Unit, they provide overall steering and support by appointing and supervising the staff, providing supplies, of course, maintaining relationship with the community and addressing challenges as they arise. So the three main components are available across all our locations in the 3 countries. But then the project is also testing other collaborative platforms or other elements of the project, which are also only present in some component, in some area, geographical area of the project. We have what we called the Community-Based Observation Network, which was established in close collaboration with our partner TRIM. And it's composed of community observers, which are trained to monitor weather parameters such as temperature and rain, and other weather-related parameters and data, which are relevant to One Health. All these data are shared, are observed, report and recorded on what we call the TreeMap information management system that help us to analyze data and feed back all the information to the community. Information that goes back to the community are used for community discussion on weather impact on health of humans, animals, and ecosystem, but are also used to support seasonal report and drought assessment, working together with the local and national institution. The community rangeland health workers, on the other side, is a pilot that has been implemented by our partner Hillary, specifically in Ethiopia. We have recognized that in the triad, speaking about community-based actors, we do have community-based actors for human health and for animal health, but we were lacking community-based actors for rangeland health. And so we are testing this new approach, and the community rangeland health workers provide specific rangeland health services, like, for example, information, but also technical assistance on the prevention and management of invasive species, or beekeeping, information and technical assistance on preservation of trees and cultivation of specific grass, for example. They also assist in strengthening participatory rangeland management as a framework for improving rangeland health. And they also support collecting data on rangeland degradation and restoration trends that are then used by the consortium to support decision making. What happened in the first phase? These are quickly some results of the first phase. We managed to establish 22 One Health units, which are supported by 8 One Health task force and 38 MSIP. And as you can see there, we managed to reach over 186,000 people through curative and preventive services, and over 1,600,000 livestock through vaccination. But I think that what is more important as a result is also the documentation and the materials that we managed to develop. We have developed an operational standard procedure which help us to support the establishment and maintenance of the 3 collaborative platform. So it gives us clear guidance on how the platform has to be established and then maintained over time. And then we develop a package of training materials that helps to operationalize the One Health approach in pastoral settings. And of course, through this package of training materials, we have trained quite a number of trainers among the local authorities and service provider to support the delivery of integrated services. Still on the impact, thanks to the support of Hillary, we have conducted participatory evaluation, qualitative evaluation of care-seeking behavior before and after the introduction of the One Health unit. And these are just examples from Filtu in Ethiopia. And you can clearly see that the community have a clear perception of how the health-seeking behavior have improved with the introduction of the One Health unit. And if we look specifically at the added value of the One Health unit, this is a study, a qualitative evaluation study that on the One Health unit in Kenya, underline how the key attributes that are mostly appreciated about the One Health unit is service accessibility, first of all, the integration of services, but also how the community is directly involved and engaged in service delivery and in planning and implementing service delivery. In particular, for example, integration was particularly appreciated because before the introduction of the One Health unit, women, for example, were forced to choose whether to seek care for their children or seek care for their animals. But now, since services for human and animals are provided at the same time in the same place, this is an extremely added value for the community because they can go at the same place and receive both services. So what are the special features of this program? First of all, the model is flexible and scalable. You've seen the 3 different models that adapt to different contexts across the 3 countries, and I would say across all the locations. And of course, it's scalable, and that is also our hope, to be able to adopt it at a wider scale. There is a strong community engagement, which promotes its sustainability in the long term, but also ensure its acceptability from the local community. There is a tangible incorporation of the environment. We believe that, and we have seen from our experience, that integration of the environment component in One Health initiative is not always common. What we have tried to do is really to make sure that the environmental component is always there, and that we work at an equal way between human, animal, and environment. The strategic partnership, of course, is an added value, the complementarity across the different partners, but also the strategic partnership with the local authorities, the local communities, and of course with our donors, which are the key changer, I would say, because they promoted a long-term commitment. And this gives me the opportunity of briefly explaining the financing mechanism and underlying how the long-term commitment of SDC, the Swiss Agency for Development Cooperation, which believed in the model and supported the initial phases and committed for 12 years, allow us also to mobilize other resources. So SDC supported the project for 50% and acted as a catalyst, unlocking wider multi-sector collaboration and at the same time attracting more additional partners, additional financing partners. And you can see there are some of the partners that supported the implementation of the program. At the same time, this long-term horizon gave us the opportunity to test the approach and now to generate evidence. So there is a growing recognition of the approach that will help us to mobilize and advocate for the recognition of the approach at the local level and specifically in the 3 countries, mobilizing hopefully for more domestic government funding in the project. I'd like just to conclude with a few lessons learned. The One Health model, or the One Health unit model, is effectively enriching hard to reach and underserved population, including during emergency, which are quite common in this part of the world, mainly because of the recurrent drought situation of the past years. The community-based infrastructure like the MSIP, but also the community-based observation network, combines scientific with the indigenous knowledge, and this helps prioritizing risk and informing early warning, resource allocation, and also outreach planning. What came out quite clearly in phase 1, and it's becoming even more clear in phase 2, is that we need government leadership and policy alignment to replicate and scale at a wider, on a wider area. And what we also realize is that women participation in collaborative platform, and specifically through the community-based collaborative platform, is key in addressing the systemic inequity and gender imbalance. And another very important lesson learned is that the multidisciplinary governance of the project, including the 3 partners, but also the different departments from the government and the different representatives from the community, are enabling a holistic and adaptive response to the multi-dimensional health challenges that these communities are facing every day. I'd like to leave you with this quote from one of our users, one of our beneficiaries, that really underline how the integration of services is key for this community. I've never heard and seen such a team treating us and our animals at the same time and place. It is wonderful. So with this, I thank you very much, and I'm happy to answer any question.
Thank you, Miko, for this very interesting presentation. And I think we're going to have more Q&A at the end. So I will leave the questions for later after Lucy presents. So now we will move to the second presenter, Dr. Lucy Keats. She is an Associate Director of the Wildlife Conservation Society Health Program. Lucy is a veterinarian specializing in conservation medicine with more than 2 decades of experience implementing transsectoral multidisciplinary One Health projects at wildlife, human, domestic animal interfaces around the globe. She is a passionate advocate for locally driven wildlife health surveillance networks and co-benefits of ecosystem-based prevention approaches. Lucy will be presenting the solution Wild Health Net Southeast Asia, operationalizing wildlife health surveillance for One Health. Wild Health Net is a regional network that strengthens early detection and response to emerging zoonotic diseases by building wildlife health surveillance capacity. It translates One Health principles into an operational multi-country framework that connects local practitioners, governments, and research institutions. Lucy, over to you.
Thanks very much, Rana. And thanks, Nicole, for a super fascinating presentation. Can you guys see my presentation okay?
Yes, we can see it.
Okay, perfect. So Verena already gave an excellent introduction to our PANORAMA solution we're presenting today. And this is a WCS initiative called Wild Health Net, and it's very much a collaborative approach to building locally relevant wildlife health surveillance systems directly for One Health intelligence, so integrated with national platforms. So a little background on why this is important to us and why we think it's so important for One Health. But WCS is a field-based conservation organization, and our vision speaks to our recognition of the intrinsic connections between ecosystem health, wildlife, domestic animal, and human health. And we appreciate that healthy and intact ecosystems are really the foundation for the health and well-being of all. And a big component of that is to understand the health of the ecosystem, the wildlife, and the communities that rely on it, and try to mitigate emerging risks. So we have an embedded health program within WCS with some key priority areas that we work on. We're a WOA collaborating center for research, diagnosis, and surveillance of wildlife pathogens. And wildlife surveillance is really a critical component of all the aspects of our work. And people still ask, why is wildlife health surveillance relevant for One Health? But it's the majority of emerging infectious diseases in people are zoonotic with wildlife origin. So identifying pathogens in wildlife can really help serve as an early warning sign and help mitigate risk for pandemic prevention, identifying wildlife pathogens both in the animals themselves, but also in the livestock and communities such as those Nicole talked about, that all of the communities we work with in and around our protected areas tend to have free ranging and backyard domestic livestock, and the diseases can spill both ways from wildlife to the livestock and back. And so understanding these pathogens and mitigating them is really important for food security for communities that rely on bushmeat, but also for the sustainable economies and for the food security and safety for the communities with domestic animals. And then, of course, there's the intrinsic value of species conservation and ecosystem integrity, because actually the loss of keystone species from wildlife diseases can have significant cascading impacts on the ecosystem as a whole, from pollination and as well as food security, predator-prey loss, and changes in whole food chain systems. So whilst we'd kind of been involved in research and surveillance for specific pathogens, and that still has its importance, we really realized to leverage the benefits of wildlife health surveillance for One Health, it's important for maximum effectiveness and sustainability to develop sustainable networks that are integrated with national One Health systems and platforms and frameworks. And this is where the Wild Health Net solution began. And we had support over a decade, really, starting with USAID project funding and EU funding, and then US Department of Defense, DITRA funding, to develop wildlife health surveillance capacity and networks in Southeast Asia. So a key component we realized to make these networks functional is that they have to function and be coordinated across all One Health sectors from local levels up to the national levels and then back for response. And you have to have buy-in and you have to have coordination and communication across all the different sectors at all these different levels in order for it to be functional. So the main building block at the beginning of this project that is absolutely critical is building these networks, identifying key actors, and bringing them together. And a key component in many countries, including in the countries where we worked, in Laos, Cambodia, and Vietnam, is that wildlife health often falls outside of the mandates of existing agencies and actors. There's often the environment sector who focus on wildlife management and wildlife monitoring, and the animal health sector or livestock sector, but they're focused on production animal health. And the actual health of the wild animals, surveillance and disease monitoring and management often falls outside anybody's responsibility, so has tended to be neglected. And wildlife health surveillance, whilst obviously important and bringing benefits, is extremely underfunded and tends to be lacking. The World Bank did a survey a few years ago, and they found that in over 67 countries, there was little to no wildlife surveillance operational. So this takes a lot of time to really understand the actors at all these levels, to build these networks, to build these trust and partnerships from the communities, working with frontline actors who are in contact and observing wildlife on a day-to-day basis, such as protected area rangers, with the veterinary authorities, public health authorities, and then up to the labs, the data analysts, the policy makers, decision makers, and response coordinators at the national level. And the majority of donor cycles and financing opportunities do not really enable the time to build these, and they do not enable monitoring and metrics or projects that reflect this process. And this is the key to developing a locally relevant, functional, sustainable network. So while we were developing this, we recognize they're very different in every country. These are the examples of the networks that were developed and kind of the mapping of the networks and the different actors in Cambodia on the left and in Laos on the right. So you can see that they involve a huge number of different actors and stakeholders. There's just some of the examples on the left, from the field, the front lines where we're observing wildlife, up to the national level. And in both cases, when these networks were finalized and developed, we have a network assistant coordinator who's embedded in a government agency, normally wherever the WOA representative for wildlife sits, because they're responsible for reporting wildlife diseases outside the country, and that often makes most sense within these country networks. And they really help facilitate this coordination of data coming in from the field and leading up to action. But all of these different agencies and ministries and actors have differing priorities and differing responsibilities. So once we've defined, a key component is defining these roles and responsibilities within this network, in particular around the wildlife health sector. And then we work to try to co-create protocols that can feed into national legislation to make this network actually truly effective, prioritized, financed in the long term, built into national planning, and functional in a sustainable manner. And to create kind of these networks and building of trust and recognition of the importance of wildlife health surveillance, we both conducted scanning surveillance for wildlife morbidity and mortality with communities and rangers around protected areas. But we also worked across these One Health ministries and sectors to identify shared priority pathogens for targeted surveillance. So these included like rabies, highly pathogenic avian influenza, African swine fever, and some endemic pathogens like rickettsial diseases. So by piloting these networks and the surveillance in the field with priority pathogens, successfully identifying those and managing a coordinated response, all the stakeholders could see the benefit, and this enabled increased buy-in as we went through, and then ultimately towards legislation adoption. So once you identify all those key actors, obviously capacity development and supporting the technical expertise needed at the different levels is critical, particularly with dealing with some potentially zoonotic or dangerous emerging pathogens in wildlife. So it's really important that appropriate biosafety is integrated, as well as appropriate cultural messaging, especially with communities that are reliant on wildlife and live on the front lines. We want to avoid culling of wildlife, which often increases spread of disease. And we really want to be respectful and supportive of these communities with different cultural identities and different acceptable norms as to bringing in WASH and different health and hygiene processes, and not make them afraid of their food, but understand how they can be reliant and live and continue with their cultural traditions, but in a more safe and effective manner, and contribute their extensive knowledge, experience, and eyes in the ground towards wildlife surveillance that can then feed back and benefit their communities, their health, their animals, their health, and their food security and safety. So we identify capacity and knowledge gaps across those levels, but we developed core competencies and training for people from the community and rangers levels up to the wildlife health coordinators, up to the laboratories and the decision makers. And we developed key training materials in the different languages in Lao, Khmer, and Vietnamese, and they're now available in French and Spanish also, for training, videos, presentations, and key pocket guides, because with these field actors, they're not going to take a massive PowerPoint presentation printed out, all these big protocols or documents to the field. So having more accessible, locally relevant training materials is really critical too. And then there's the key element of getting the data from the field up to decision makers. And ideally, if you really want these to be early warning systems for wildlife and human health, then we want that to happen fairly quickly. But to be sustainable in resource limited settings, we wanted to try to identify existing technologies that we could leverage or use in platforms. And one of these is the smart conservation tool. So in over 1,000 sites globally, rangers were already patrolling protected areas using this tool called SMART, which is on cell phones and was originally designed for protected area patrols and management to observe wildlife, observe poaching or other threats to wildlife. So rather than adding a whole new activity and action of wildlife surveillance, which we knew would be harder to get buy-in for and require greater financial and human resource investment and be less likely to be sustainable, we leverage this existing tool and activity and just were able to add, it's a very flexible tool, so you can add different monitoring modules. And we added and developed a wildlife health monitoring module that collects information on wildlife morbidity and mortality and on the environmental context, which are really important to understand to see what the stressors or drivers might be and long-term impacts. So these rangers, while they're continuing their patrols, can just add this. If they see wildlife morbidity or mortality events, they can report it as part of their regular activities, which makes it much more sustainable going forward. And this has been iteratively improved with these actors on the ground to make sure it's not overburdensome, and has now been used by communities on the front lines as well as with rangers for reporting. And anyone who's been involved with wildlife health surveillance knows that the data is actually quite complex. It tends to be more complex than just traditional livestock surveillance data, given you're collecting all this ecological data as well, and data around the species, single and population health. So moving forward, appropriate tools that can be leveraged by governments and local actors to manage that data was also a key component. And then if you're working hard, training communities and taking their time to collect this data, it's really important that they see a response and see the benefit and see the point of reporting the data. So there has to be effective communication of that data up to the central level and then effective response. And some key examples of where we've been able to support communities who've reported pathogens, detection of lumpy skin disease, which is a livestock pathogen that had spilled over into wild endangered bovid species in Cambodia. And after that was detected, we were able to support ring vaccination around the protected areas for the domestic animals in those communities, which obviously benefits the communities and their animal well-being and health and their financial security, as well as benefiting the wildlife and conservation. The World Health Networks also detected the first outbreaks of African swine fever in wildlife in Southeast Asia. African swine fever spread very rapidly across China and then across Southeast Asia and has devastated wild pig populations. And given there's a lot of contact and interface between wild pigs and village pigs in many of these areas, this was a critical pathogen to detect. So when we've detected it in protected areas through rangers and community members, we've reached out with those communities, helped enforce their management of their livestock, biosecurity. And this poster on the bottom left is from Laos, was a lot of community engagement work and raising awareness of the pathogen, what's going on, and how they can protect both their animals and their wild food source from this pathogen. The same with high-path avian influenza. We've detected transnational outbreaks of HPAI on the Cambodia-Vietnam border, and we're able to support the government with response and also with community outreach with community members who have, there's a lot of free-ranging, mixed-use wetlands where ducks and poultry are raised on wild wetland habitats where we get a lot of migratory birds passing through. So working with those communities to let them know that we've detected the pathogen and what they should look for in their domestic animals to make sure that they don't eat any dead or dying sick poultry, to report anything that they see, and how to mitigate risk both to them and to their domestic animals. And we've also detected rabies in wildlife to then form community response to discuss PEP for rabies, preventative vaccination, but also the importance of post-exposure vaccination should people be bitten both by wildlife but also by domestic animals, just raising awareness. And then pathogens relevant to conservation, like elephant herpes. And then beyond communicable diseases, we've also identified poisoning events through this network, including of vultures. And this has had impacts on both human populations and on vultures, both from the ecosystem services they provide, but also because humans were exposed to the same poison that we identified in the vultures that was being used to poison livestock. And we also see it being used to poison carnivores, and then people and their animals are being exposed to the same poison. So another One Health threat, but a non-communicable one that wildlife health surveillance can help. So some of the really key challenges that we saw in these countries, but we see more broadly, is, as I said, just a lack of institutional mandates for wildlife health, these competing priorities across sectors. So it's really important to try to find common themes to work together. And this chronic continued underfunding of the environment sector and prioritization for funding the environment sector is foundational for One Health. And that, of course, has a knock-on impact on funding and financing for wildlife health surveillance. We tend to see much more funding for human health and agricultural health. And so this is the environment sector will always be resource constrained. So it's important to try to find ways to leverage existing tools and existing structures to make it more affordable and sustainable. Building these functional networks takes time. And as I said, this is not facilitated or enabled by traditional donor mechanisms. So we were lucky in these cases and some other donor sources from USDA and others that have really recognized that this is a key component of effective surveillance systems. And then data management platforms were lacking for complex wildlife surveillance data that could then be integrated into One Health platforms. But despite all these challenges, we did have key successes. As I spoke to, we detected multiple pathogens in livestock and human health relevance, and were able to support effective response. So we've seen an improved detection of wildlife health events and strong communication between the sectors and across the networks as a result of this improved understanding and appreciation of the links between wildlife health and human and animal health and well-being. And that's led to this more effective One Health investigation, response, and mitigation, and ultimately now to these wildlife health surveillance protocols being integrated into the national policies and strategies in both Laos and Cambodia. And that is really critical for sustainability and these being adopted by national governments going forward. So as I mentioned, we were really fortunate with our funding sources, and long-term funding from international donors was critical to really form and initiate these networks and help them become functional and develop technical capacity in the initial phases. And having support and buy-in from the different stakeholders at all the different levels was critical, and it took time, but we really have strong support and buy-in, and we still do today, which is really critical. We still have community members reporting high path outbreaks in Cambodia as we speak, and other great support from the government as well. And then having adequate human personnel without too much turnover is one challenge we've seen, but we've been lucky with certain positions and being able to hire, due to funding, these network coordinators embedded within government. We see a lot of human personnel turnover in these agencies in national government. So often you can put this time in to build capacity in these people, key personnel as part of these networks, and then 2 years later they're moved to an entirely different department, sometimes even more frequently. So that's kind of a challenge, but can be an enabling factor if it's not an issue. And then leveraging these great cell phone-based technologies in the field that are already being used by tens of thousands of rangers globally. So as a result of the success of the program in Laos and Cambodia, we've been able to take these core lessons learned, these core building blocks, and the training materials, because they were all designed to be adaptive to different settings in Madagascar, the Congo, Latin America, and Alaska, to start to work with partners there to build locally relevant wildlife health surveillance in their countries. And we've leveraged the same tool. Peru is a really impressive example of where we leveraged the same approach and a priority pathogen, which was high path avian influenza, because a few years ago they had an absolutely devastating outbreak as it spread south along the coast of Latin America with migratory birds, and it absolutely decimated wild bird and wild mammal populations. The government realized that they really didn't have wildlife health surveillance in place or these functional One Health networks. So since then, they've really prioritized wildlife health surveillance. They've developed a One Health platform, and this is an integrated approach. We started training in the wetland habitats on the coast, and they recognized it was so valuable that they've rolled out their ranges using SMART across all 78 protected areas in the country now. And so just up till May 2024, so we have more recent data too, but they recorded almost 2,000 health events across their protected areas. And so you can see the significant success if it's really adopted by governments at a national level. We were able to, through this process and ongoing funding with the Wildlife Health Intelligence Network, develop a really comprehensive data service that will be able to be free and open for lower middle income countries, which can accept data from really the diverse wildlife health surveillance that is being conducted in the field, and help manage that data in a secure private platform, but one that's interoperable with other One Health platforms. So key takeaways, wildlife health monitoring is a critical foundation for One Health. It really contributes to the health of wildlife, people, livestock, and well-being. This lack of institutional mandates for wildlife health is extremely common, and overcoming that and defining roles and responsibilities is absolutely critical to develop effective wildlife health surveillance networks. And strong communication and collaboration across sectors from all levels is really vital for an effective network, both for detection, but also for the translation of data into actionable information, and then an effective coordinated response that supports conservation and communities and human health. So taking the time to build networks is essential. I can't say that enough times or enough emphasize it enough. It's still really challenging given most project cycles are often only 2 years, and really to build these networks takes 1 year, and then you want to pilot and iteratively improve processes and then embed them within legislation. And that's what makes it adopted by countries more sustainable, more likely to be integrated into financial plans and national plans going forward. So this remains a challenge, these donor cycles, and the fact that the environment sector is often the least funded of all, and preventative approaches tend to be less funded. So we hope we continue to see kind of improved recognition of the importance of the environmental sector and One Health, and primary and secondary prevention in One Health financing. Because that initial phase, financial support for lower middle income countries, will remain important given competing priorities and resource limitations. We've recognizing the importance of this, but that we can't do it alone. We help convene a wildlife health intelligence network that's kind of building and collating resources to help support wildlife health surveillance in different countries, including those developed through this project, and the theory of change for building stronger wildlife health surveillance systems that has also come from this. And these are open source and will be open to everybody. And this is a global community of practice working together to support development of wildlife health surveillance networks. So there's the link to the solution itself and my contact information if you'd like to learn more. But thanks so much. Happy to answer any questions about the initiative. And I will stop sharing.
Thank you very much, Lucy. Also very interesting presentation. So now we're going to have the floor open for questions. I already saw in the chat a question to Mikol. I don't know if you, Pascal, want to directly ask or...
Hello, everyone. It's okay. I translate my question by writing, just because it's always said by many people that the community are involved, but I feel that it's sometimes they are involved by helping the project to be in place. But I wonder how their knowledge is really taken into consideration for co-building the projects, not being only up to bottom, but really a co-construction, co-building. Thank you.
Thank you very much. Miko, you want to answer?
Yes, thank you very much. Thank you very much for the question. I think it's very relevant and very important. In this case, the project builds on an operational research that was conducted back in 2015, where we worked directly with the community. So we had an anthropologist leading a team of, again, a multidisciplinary team of experts, and discussing with the community the effectiveness of the One Health approach to respond to their challenges. So that was the starting point. So the community themselves was involved since the very beginning in designing the approach, or let's say the model. What we are doing then is that through the multi-stakeholder innovation platform, community remains really active in identifying specific problems and requesting to the service provider to address them. simple example, a specific increase in diseases in the community, the MSIP reported to the One Health unit, and to make sure that service provider address it, not only in terms of treating, but also in terms of creating awareness on that specific disease. Again, the community realized that there is a specific need in a specific village, so the movement plan of the One Health unit is decided together with the MSIP. So the One Health unit does not go to a specific place every time, but move according to the needs specified by the community. Last example, because I also want to leave the space to Lisi for other question, is specifically in the community-based observation network, where we try to integrate the community knowledge, so the indigenous knowledge, the traditional knowledge. So together with monitoring weather data, we are also encouraging and ensuring that community observer monitor traditional practices, right? For example, clouds, or the appearance of specific birds, or the pastoral community used to read the intestine, animal intestine, to predict the rain, and so to inform how the community has to move. So what we are trying to do in our bulletin on weather is to include both the scientific knowledge, so we report data specifically on rain and temperature, but also all these observations together with their meaning, so that we are sure that discussion do not only happen around the weather or the rain, but also on what the community has seen and is used to rely on for planning and decision making. Thank you.
Thank you very much.
Thank you, Nicole. I see a hand raised by Dr. Farak. Please go ahead.
Thank you so much. This is so interesting. So my question it would go to Nicole. Thank you so much. I'm like how to sustain this community participation, since the funding is coming from outside, and as I mean I used to work in the global fund. So when the fund was withdrawal, everything is collapsed. So how to sustain this for forever? Thank you.
So can I proceed, Verena?
Yes, go ahead.
So thank you very much. I think that sustainability is a challenge in any project. But I think that we are lucky for that because of the long time period that we were given by our donor. And this is really helping us to build together with the community. So we started with the model, and what we are trying to do now is organizing studies, cost effectiveness study, and generate solid evidence that can help us to advocate for institutionalization of the approach within the local authorities. At the same time, what we are trying to do is also to study the willingness to pay and the willingness to contribute by community. At the moment, services are provided for free. But we do acknowledge that this is not sustainable in the long run. So we are trying to integrate the system in the actual system. So linking with already existing health insurances at the community level, trying to create new One Health, community-based One Health insurances at the community level, and trying to understand how much is the community willing to contribute to these services. So that by understanding these, we can then inform proper planning as a consortium. And by consortium, I do not only include the three organizations, but also with the government. How can we really sustain it in the future? And of course, this is also possible because we have a long-term horizon. So we are not rushing doing. I mean, I'm often used to projects that last for 4 years, and that is, of course, not enough. But we need longer term program to engage and maintain engagement of the community in the long term. Thank you.
Thank you. Thank you.
Okay, thank you very much. There was a question by Cletus. I'm going to ask it. I'm just gonna find it. Because he said he has issues with. Okay, it's also a question for you, Miko. He says there's a project on community health engagement, which is aligned to his presentation. Oh no, I think this is something else. You already answered.
Verena?
Yes?
If I may, the question is, you wanted to find out if One Health has been implemented in Zambia, and if so, to highlight to me the office in Zambia for this project. Thank you.
Thank you, Rosalind.
No, unfortunately, no. At the moment, the project focus on the three countries that I underlined before, so Ethiopia, Kenya, and Somalia. But again, what we are trying to do is to expand it and scale it. And I saw someone with the chat. I mean, we will be really happy to collaborate with also other organizations and other government to expand. At the moment, we are generating evidence to support this scaling, but there is nothing in Zambia at the moment.
Thank you, Miko. Are there other questions? Otherwise, I would have a question for Lucy regarding the stakeholder collaboration. You said that Wild Health Net bridges this traditional siloed sectors, no? So you connect field rangers, district veterinarians, and national coordinators with one surveillance network. And I would like to know, like, which mechanisms do you use, which go beyond workshops and training, to sustain this trust-based collaboration among this heterogeneous group, especially considering this interagency competition you often have, and this data sharing reluctance. Especially now, there's like a lot of data sharing reluctance, and how you overcome this issues that can undermine the system you have.
Thanks for the question, Verena. Yeah, and it's, some of the answers are linked to what Nicole was saying about sustainability, working with communities too. So it's really helpful to have that initial long-term funding to help develop these programs, because then it gives you a chance to demonstrate the benefits. And I think a critical component to having sustained collaboration and buy-in is being able to demonstrate the benefit to the different stakeholders involved, from the community level up to the national government and across all sectors of the government for this particular approach. And anything requiring One Health, really. But so beyond just the capacity building and training, which I would say, again, needs to itself be iterative and repeated given turnover of staff, and just the fact that this might not be their key activity, a one-off training is not effective. So continuing to have iterative training is critical, but continuing to support collaboration and coordination mechanisms. So we have the network coordinator, and we have regular meetings through a One Health platform, which brings together all the different actors and stakeholders at the national level. But we also do have regular meetings and repeat coordination at local levels as well. And I think that's critical for sustained coordination, for maintaining trust, especially with turnover of staff, and just keeping it in the mindset of everybody, and for iterative improvement, for ways that make it work better in the long term. It's also been really critical. As I said, we combine both scanning surveillance with targeted surveillance, so identifying priority pathogens that were relevant across those different sectors and their different priorities was really important. And that enabled us to demonstrate those key early successes and the relevance and the value to the different sectors. So that was really a critical component of buy-in. And actually right now, my Cambodian colleagues are at a tabletop response exercise, which is one component that helps to bring together the different actors and practice in these sorts of events so that we're continuing improvement, but it's continuing to work together. And the Cambodian CDC just highlighted how important this network was for both African swine fever development, but also for the poisoning event that I talked about, that would not have been detected by traditional surveillance. So having those key successes that are relevant across the sectors from the community level up to national government have really helped to push that forward. And then that's kind of on the national level, and then and having that integrated into legislation now is also critical for long-term sustainability. So that's been really helpful for both Cambodia and Laos, and has led to the government reaching out to embed this approach and include this approach as part of their pandemic fund projects that are on the ground running now. So that helps with ongoing sustainability. And really at the international level, things that can help, and why we also engage at the international policy level, is that having wildlife health surveillance and the environment and prevention integrated into these international frameworks, such as the IHR, the International Health Regulations, the WOA performance of veterinary services, the CBD biodiversity health agenda, really help to raise the awareness of the importance of integrating wildlife surveillance into these national systems. And these are often global standards that countries already report against. And so it provides kind of a formal incentive to consider wildlife surveillance in an integrated long-term manner and to build that international planning and national system. So it's kind of a multi-pronged approach. Sorry, that was a long answer.
That's great. It's very important. I don't know if there are other questions. I don't see any in the chat. Otherwise, I can keep going. Yeah, maybe also looking, even though you already mentioned it a bit, Nicole, looking at the barriers. You said that this pastoral communities, they're highly mobile and underserved and vulnerable to a lot of shocks. So which are the barriers, looking at logistical, cultural, or institutional, which proved to be the most challenging during the implementation? And to what degree did this three different modalities effectively address this diversity on local context? And then also looking a bit at the government level, you said that you have sorry, I lost my thoughts.
The One Health Task Force.
Yeah, you have the district level and the multi-stakeholder innovation platforms at community level. And so you have these different governance structures. And how do you make this an effective coordination and avoid tension or where accountability gaps can emerge? So how do you handle that?
So let me start by quickly answering about the barriers. I think that the key barriers, at least in terms of infrastructure, it's really our starting point, the fact that these communities really lack infrastructure and health system. And when I speak about health system, of course, I speak about both the human health and the animal health system. And this was really our starting point and our major barrier, how to overcome that. And I think that the key issue with the project was really to be flexible and to identify a model that could specifically address the needs in a specific community. And so the three models really respond differently to the barriers that you find in different contexts. So in Ethiopia, where health system is better off compared to other settings, for example, it was useful to use facility, or let's say, yes, to provide service delivery, to provide services directly from static facility, fixed facility. And it was a fact. But still in that area, what is happened often is that you have a drought or you have conflict. And so another barriers come there, because even if you have facility, people cannot reach the services because of conflict or because they are isolated in a specific area. So the solution was to be, in that sense, flexible. So we do have a model that is for facility-based services, but the collaboration and the trust and the relationship that we have established among service provider and local community help you to respond quickly to the emergency and to say, okay, now what we need is for that static services to provide mobile services in other facilities. And so I think that the way we really we were able to respond to the barriers was really to be flexible, have a standard procedure to set up a system, but keeping in mind the flexibility and the adaptability. The key issue that we always report is that one does not fit all. So we really need to be flexible there. As for the other question that you asked for the two different governance mechanisms, so, well, the One Health Task Force, which is the collaborative platform for local authorities, and the MSIP, which is the collaborative platform for community members, they have their own mandate, their own term of reference. They meet on regular basis independently. But what we have created is space for them to communicate and to share information and data, and to openly communicate what is happening. So I think that the structure, especially the MSIP, the community structure, helped a lot in creating the trust and improving the relationship with local authorities. So the MSIP now is seen as a mean to collect, to gather all community issues or community complaints, and that the MSIP is now becoming empowered and strong enough to report these to the local authorities through the One Health Task Force. So this communication help to address challenges together. So, for example, apart from these, which happen on informal way, we have also created spaces like the annual review meeting, in which the One Health Task Force and the One Health Task Force, the One Health Unit, and the MSIP work together to review progress and challenges and to address them together. Or again, the joint supportive supervision, in which the One Health Task Force move on the field together with the One Health Unit, and there have the opportunity to observe what is happening and to meet with the MSIP and discuss challenges. So I think that this is the main issue, main way in which they can really work together and overcome challenges, which of course are always there. For example, the lack of funding. The MSIP, the community normally do not have readily available funding, and unfortunately we didn't foresee specific fund for the community within the project. But I think that through their continuous engagement and empowerment, what we have seen that, and creating this exchange and this collaboration, we actually promoted a way of communication, right? So, and I can give you the example of what happened in southern Ethiopia, in one district in Filtu, where the community identify the lack of services as one of the key issues. So there was a health facility which was destroyed because of very bad weather condition. And so they gathered together and they say, okay, this is an issue, we need to solve it together. So they communicate with the One Health Task Force, they all gathered together, and they decided that government, community, and of course the partners will collaborate in rehabilitating the health facility. So I think it's just supporting the communication like we always say in One Health, communication, coordination, and collaboration. So making sure that we keep the door open for communicating and exchanging issues and problems. Acknowledging that not all the problems and not all the issues can be immediately solved by the project.
Thank you very much. It's so interesting. I don't want to take over and ask a lot of more questions, which I have. Are there other questions coming up from the audience? I saw that there was another point from Kletos. Maybe, I don't know if either Lucy or Miko, you can answer if you have had this. He says there's a lot of human-animal conflicts in our communities. Sharing of natural water bodies with human and animals is one of the problems, source of concerns. And I don't know if you have like some example on how to overcome this.
Miko, go ahead if you want to. I can speak to it, but I'm
You
sure
can
this
go
is
ahead,
something-
Lucy, go ahead.
Well, I'm sure this is something you face, particularly in your communities where water is a more challenging resource. So I've mostly worked in communities that are less arid. So, but we are seeing this increasingly as an issue given climate change in some of our communities and our more remote communities. And we have some surveillance work actually looking at to better understand what species are sharing those water bodies and what pathogens they might be sharing, and looking at AMR as well as pathogens. But I think it comes back again to an infrastructure issue and working with the communities to identify what alternative infrastructures might be possible, feasible, available, and culturally acceptable for clean water, sanitation, and access for those communities.
Yeah, what I want, I think that the approach is pretty similar to what you said. And I agree with you. In our communities, water scarcity is an issue. So I would say that it's not just creating health problems, but it's often creating conflict. So what we see most of the time is that because of limited availability of water, we have clashes and conflict among the different communities because of the water sources. So what we're trying to do is really, and I think that in this way, the pastoral communities are also very knowledgeable. And so it's very important to build with them ways on how to preserve and organize better access to water. I totally agree with you, Lucy, when you say that it's really essential to identify solutions which are culturally accepted. Because for our communities, but I would say for all the communities in the world, water is a key element and source. So it's really important that in this sense, we really identify solutions that are culturally accepted and that can be sustained in the long run. Yeah.
Thank you very much. I hope, Kletos, this gives you some insights on what can we do. He has another point. He says it's not just water, there's also devastation of agriculture products being destroyed by animals, which has again contributed to household hunger in rural communities. So maybe also with wildlife, I don't know, Lucy or Nico, go ahead.
Yeah, I think depending on the species and the context, there are different approaches that can help address that type of agricultural conflict. So I don't know who's working in those areas or communities, but it's definitely an issue, and I think it becomes increasingly an issue where food is becoming more scarce, which we're seeing in different landscapes. So, and then we also see this increasing conflict when there are other impacts on the ecosystem, and so prey species or traditional food sources are less available. So I think there's different approaches at the community level that can help with crop management and protection, as well as monitoring and alerts of the wildlife species and the actual landscape and ecosystem management. So it's important to kind of tackle it at all those different levels. But it's certainly an issue in many places.
Yeah, I can just add on that. I think that the community engagement in this sense is critical because we cannot adopt a top-down approach. I mean, in our case, for example, we had in one of the area in Kenya, human-elephant conflict. And of course, it's always very tricky to address them. And I think that's the only way to do it is really to involve the community in identifying acceptable and sustainable solution, which sometimes goes beyond just the simple management of that case, but we really have to work also on prevention. Yeah.
Great. Thank you very much, Lucy and Miko, for this very interesting exchange. I hope everyone got some insights on how really you can implement One Health. It's a very difficult aspect of integration of different sectors on heterogeneous groups, how to work together. But I think with the evidence you have shown, it can really have a lot of benefit working together and finding the solutions. So we come to an end, almost on time. Thank you very much to everyone and have a nice day.
Many
Thank you very much.
Marina. Thanks all for attending.
Thank you.